Welcome to AETC, the Emergency Medicine Channel. Myself, Dr. Evin Shagija. As part of our EM Rapid 2024, I'll be presenting the topic syncope, evaluation, and management. So, coming to the definition of syncope, it's actually a transient, self-limited loss of consciousness, and it's caused by a transient, self-terminating, inadequate nutrient flow or blood flow to the brain. And these episodes may or may not be preceded by the prodromal symptoms. And we also have another component, which is the presyncope, which happens as a fainting episode without a loss of consciousness. And it is actually an impending syncope. So the recovery usually is complete in case of syncope, and it's rapid with episodes lasting less than uh, 1 to 2 minutes. And the longer periods of real or apparent loss of consciousness suggest that it's not syncope or it's not just syncope alone. It will have other neurological aspects or other cardiovascular aspects to it. And coming to the pathophysiology, so basically it takes about 10 seconds of complete disruption of the blood flow to both the cerebral cortices or the brainstem reticular activating system. So this complete disruption of blood flow is what leads to syncope. And also there will be approximately 30% reduction of cerebral perfusion. And also the cerebral perfusion and consciousness can be restored by supine position, by the response of the autonomic autoregulatory centers, or by restoring a perfusing cardiac rhythm. Coming to the causes of syncope, we have the most common causes as per the Framingham Heart Study, which is 21% of the patients present as a vasovagal or reflex mediated syncope, or it can also be cardiac related syncope, which is about 10%, and orthostatic hypotension related syncope is about 9%. There is 7% for the medication related, 4% for the neurologic, and the most of the syncopes which presents are actually does not have any apparent or definitive cause for it. So that is what comprises most of it, which is 37%. And also the other non-syncopal causes of transient loss of consciousness includes the seizure disorders, the traumatic brain injury, example the concussion episodes, the intoxications, metabolic disturbances, and conversion disorders such as the psychogenic pseudosyncope or pseudoseizures. So in these conditions, the presentation will be different, and there wouldn't be any complete recovery, which we talked about before. And the patients will continue to be in the state of loss of consciousness, or they'll be having a post-ictal confusion or any sustained loss of consciousness. And coming to the cardiac causes, we have the structural cardiopulmonary disease and dysrhythmias. So the structural cardiopulmonary disease, in the structural diseases, we have the valvular heart disease, such as the severe aortic stenosis, and tricuspid stenosis, the mitral stenosis, hypertrophic cardiomyopathy, the cardiac tamponade, myocardial ischemia or infarction, prosthetic valve dysfunction, congenital coronary anomalies, cardiac masses, and tumors such as atrial myxoma. So in these conditions, basically the cardiac output is reduced, or the output of the blood flow from the heart is reduced, and this causes reduced cerebral perfusion, and that is what leads to the syncopal episodes. And in other causes is the cardiopulmonary or vascular cause, in for example, the severe pulmonary hypertension, pulmonary embolism, aortic dissection. In this also the same physiology happens, in which the cardiac output and the subsequent blood flow to the brain is reduced. Okay, and the coming to the dysrhythmias, we have the bradydysrhythmia and the tachydysrhythmia. So bradydysrhythmias are basically the Stokes-Adams attack, sinus node dysfunction, the heart block, second or third degree, the pacemaker malfunction, And tachydysrhythmias are basically the ventricular tachycardia. Torsad is the point S, the supraventricular tachycardia, atrial flutter of fibrillations. So these also causes, as we said before, the reduced cardiac output and the reduced cerebral perfusion. So coming to uh, this the cardiac causes, in both these settings, as we discussed, the heart is unable to provide adequate cardiac output, as we discussed, and in structural disease, there is a limitation in the heart's ability to increase the cardiac output to meet the demand. Both brady and tachydysrhythmias may lead to transient cerebral hypoperfusion, and the symptoms depends on our autonomic nervous system's ability to compensate for the decrease in cardiac output through the autoregulatory centers, as we mentioned before, and also the heart's structural ability to compensate for a decrease in cardiac output also influences the syncopal episode, and also the degree of the underlying the underlying cerebrovascular disease of the patient also contributes or influences the syncopal episodes. And coming to the other cause, which is the neural or reflex mediated. In this, the we have multiple causes, which includes the first one is the vasovagal syncope. In vasovagal syncope, is basically due to orthostatic when the patient suddenly stands up from a sitting position due to the failure of the autoregulatory center, patient will have a syncopal episode, and it can also be due to emotional aspects as well. Due to an emotional trigger, the patient can have a syncope episode, or it can be due to an unknown trigger as well. And in situational causes, we have the cough, micturition syncope, the defecation syncope, the swallow syncope, the neuralgia causes of syncope, and also it can also be seen in carotid sinus syndrome, psychiatric causes, breath holding causes, and as most commonly seen in children, the breath holding spells. The other causes include neurologic causes, which includes the transient ischemic attack, subclavian steal syndrome, the migraine causes, and also other causes are the obstetric hypotension, which is secondary to the medications such as diuretics, vasodilators, antidepressants, and also due to volume depletion as seen in hemorrhages or GI blood loss, reduced fluid intake, and also the autonomic failure can also cause this, and it can be either pure autonomic failure like the autonomic autoregulatory autonomic action is lost, and so when the patient suddenly stands up, he will not be able to maintain the vascular tone. So that causes the cerebral hypoperfusion, and also the other causes like the Parkinson's disease, Lewy body dementia, all of these can cause, and also the secondary causes include amyloidosis, autoimmune neuropathies, GBS, spinal cord injuries as well. And coming to reflex syncope proper, we have the vasovagal syncope as we discussed. It's actually an autonomic dysfunction and is associated with inappropriate vasodilation or hypertension or bradycardia or any of these together. And the patient might have a prodrome of lightheadedness with or without nausea, pallor, sweating, associated feel of warmth, and may also occur after exposure to an unpleasant or an unexpected sight, sound, smell, fear, severe pain, emotional distress, or instrumentation. And that is similar to the situational syncope as well, in which the patient has syncope soon after coughing, micturition, defecation, or swallowing. And the other cause is the carotid sinus syndrome, as we discussed. It is actually a reflex-mediated syncope, and it is also known as the carotid sinus body hypersensitivity. So the carotid body is actually abnormally hypersensitive, and any external pressure of the of the carotid body and can lead to two autonomic responses, mainly bradycardia and hypotension, or pause or asystole of greater than 3 seconds. And orthostatic syncope, we have the postural hypotension, And in this, the systolic BP actually drops more than or equal to 20 millimeters of mercury, or the diastolic BP falls by around 10 millimeters of mercury or more, or assuming upright posture from a sitting position. And this syncope with the postural hypotension is mainly due to the dysfunction of the autonomic nervous system. So it's also termed as neurogenic orthostatic hypotension. The neurologic syncope, as we discussed, it can include SAH, TIA, transient ischemic attack, stroke, subclavian stage syndrome, and complex migraine headache. The stroke and TIA causes focal neurologic deficit, including diplopia, vertigo, focal weakness, etc. And seizures is actually it mimics syncope and it can be difficult in certain circumstances when we are not able to get a proper history, as in if it is an unwitnessed event. And in such cases, basically, it is differentiated based on the brevity of convulsions or the absence of an epileptic aura before the event, or a urinary or fecal incontinence, and tongue biting. These are basically seen in true seizure. It's a true seizure episode, and it lacks it has the post-ictal phase. But in syncope episodes, the convulsions, even if it is present, will be very brief, and there won't be any aura or fecal incontinence, urinary incontinence, no tongue bites, and it lacks the post-ictal phases. The loss of cerebral blood flow due to any cause of syncope can result in myoclonic jerks. And when you take an EEG, you'll be able to see brain waves slowing and not epileptiform spikes. And also, rarely these have abrupt complete recovery, the seizure episode. Whereas syncope has a complete recovery, as we had discussed initially. And coming to subclavian stage syndrome, it's basically when you raise your arm, or when you raise your arm, it basically has an it's basically due to the abnormal narrowing of the subclavian artery proximal to the origin of the vertebral artery. So when you exercise with your ipsilateral arm, what happens is the blood is shunted from the vertebro-basilar system to the subclavian artery, supplying the arm muscles because of the usage of the muscle. And that causes the reduction in the cerebral perfusion because of the reduced blood flow through the vertebro-basilar system. And coming to the psychiatric disorders, it is commonly seen in generalized anxiety disorder, depressive disorder. It is also called as psychogenic pseudosyncope, or PNES, which is psychogenic non-epileptic seizures. And in this, there is apparent loss of consciousness without impaired cerebral perfusion. And the eye closure, longer period of apparent loss of consciousness, increased pulse rate and BP and all points towards this diagnosis. And coming to the metabolic or toxic abnormalities, it rarely has abrupt onset or complete recovery. It is more prolonged, gradual onset, more prolonged presentation, and hypoglycemia and encephalitis can cause coma, stupor, and confusion, but rarely transient loss of consciousness. And coming to the algorithm for syncope or collapse. So first, when a patient presents with collapse, we'll have to see if it's a loss of consciousness or is it something else. So if it's not loss of consciousness, it can be due to the accidental fall without LOC, or it can be a narcolepsy, cataplexy, psychogenic pseudosyncope, or syncope, or psychogenic non-epileptic seizures. These won't have the typical loss of consciousness. If it's a proper loss of consciousness, the next thing we'll have to see is that is the breathing and pulse present. If not, we'll have to follow the BLS or ACLS uh, cardiac arrest algorithm or the respiratory arrest algorithm. And if the breathing and pulse is fine, we'll have to see if the LOC precedes a fall event. If it does not precede a fall event, then we can the other causes can be like the patient falls down and has LOC, then it can be due to head trauma. with associated concussion, SDH or EDH. Those can lead to the loss of consciousness. And coming to the if the patient has LOC before the fall, then it can be we have to see if it's a transient LOC or like a self-terminating LOC or not. So if it's not, then we have these causes such as the ones which are gradual onset and having a longer duration of loss of consciousness, such as the toxic metabolic causes like hypoglycemia, narcotic overdose, status epilepticus, which can be convulsive or non-convulsive. Then the psychogenic status epilepticus, stroke, stroke can also present like this. And if it is a transient loss of consciousness, then it can be a syncopal episode, can be a seizure episode, it can be again stroke can also present in such a way. It can also be a psychogenic pseudosyncope or a psychogenic non-epileptic seizures. And coming to the emergency department approach to an adult patient with syncope. So once, if it's not, if we roll out a syncope, we have to manage the alternative conditions like seizure, stroke, head trauma. And if it's a proper true syncope, we'll have to begin with our history, examination, ECG, and the diagnostic test has to be sent. So once the diagnosis is established, based on that, if we have a clear cause for it, then it will go in this part of the table. Uh, if it doesn't, if it's an unexplained syncope, then we'll have to perform a risk stratification. So based on that, we will be planning further regarding admission or disposition of the patient. So if it is high risk criteria include history of any cardiac disease such as heart failure or any structural heart disease, or if the patient has a family history of sudden cardiac death at a younger age, mostly less than 50 years of age, or if the patient is older age and associated has many comorbidities as well, then it's a high risk criteria. If the patient has shortness of breath with event or during the ED evaluation, or if the patient has a persistent low BP, less than 90 millimeters of mercury systolic, and if there's any abdominal ECG findings like erythemia, LBBB, ischemia, and all. And also, or the patient has a hematocrit value less than 30, which can indicate GI blood loss or any other hemorrhage as such. And or the BNP or HS troponin is elevated, it could imply a heart failure event or ischemia, myocardial ischemia or infarction. Okay, and in such patients, we'll have to admit them for further evaluation and cardiac monitoring. And if it's an intermediate risk based on the resources available, will or the based on the patient, we'll have to either admit or dispose. If it's a low risk, we can reassess and ensure if the patient is symptomatic, we can discharge with follow-up. If in the other part of the table, if we have a clear cause for the syncope, we'll have to see if it's a dangerous cause. So the dangerous causes include the cardiac causes, the pulmonary causes, neurologic, and hemorrhage. So the cardiac causes include, as we discussed, arrhythmia, ischemic heart disease, valvular heart disease, the pedicular effusion, tamponade, and the pulmonary causes, which is the pulmonary embolism mainly, and neurologic causes such as SAH, subclavian steal syndrome, TIAs, and hemorrhage includes GI bleed, trauma-associated hemorrhage, ruptured spleen, ruptured ectopic pregnancy, ruptured ovarian cyst, and in such patients, we'll have to admit and we'll have to do the appropriate specific managements for these. And in the other part, if it's not a dangerous cause, it can include the causes which we discussed earlier, such as reflex syncope, vasovagal, carotid sinus hypersensitivity, situational syncope, medications related, orthostatic hypotension. So in these patients, mainly we'll observe and discharge them, and we'll follow up on an OPD basis. Okay, and coming to the history, so we'll have to take a detailed clinical history from the patient as well as from the witness. So most of the time, the patient won't be able to give the complete history. They will only be able to give the prodromal symptoms mainly, and the rest of the history depends on whether the event was witnessed or not. So that is the main major limitation in the history taking, and we'll also have to see based on the age group the patient. So if it's a younger age group, we not need very much if the patient has no other comorbidities. It might be mostly a vasovagal syncope, but if the age becomes more on the higher side, if it's an older patient, then we'll have to see for other cardiac causes or neurologic causes as well. The risk increases, and the onset also is important. So if it's uh, abrupt onset or is it a gradual onset? So we have differentiate between the how the onset of the loss of consciousness is, and also the duration of symptoms have to be seen. So if it is if the patient has a short duration of the loss of consciousness, then it can be more like a syncope. If it's a prolonged duration, we have discussed earlier the causes, the toxic metabolic causes, seizures, stroke, etc. And we will also have to ask about the patient position, like how whether the patient was sitting, standing, or lying down. Because if the patient is in supine position or sitting position and is having a syncope episode, it is more dangerous. And also, we'll have to see for any environmental stimuli. Because as we discussed about the situational syncope, in those patients, the environmental stimuli is important to differentiate that type of syncope. And also, we have to see for any strenuous activity or exertion or arm exercise. The strenuous activity or exertion can imply a cardiac cause for the syncope, and it's more of a red flag. Whereas for the arm exercise, we have discussed the subclavian steal syndrome. So that also has to be probed into. And also, we'll have to ask for the symptoms. The associated symptoms can actually explain why the syncope has occurred. So we'll have to probe into each of the systems separately. We'll have to see for the neurological symptoms such as the aura, headache, diplopia, vertigo, focal weakness, etc. And the cardiac symptoms, we'll have to ask for chest pain, palpitations, shortness of breath, etc. And we'll also have to ask for abdominal or low back pain to rule out any abdominal aortic aneurysm, rupture, or aortic dissection. Also, we'll have to ask the post-syncopal events because it's important because in case of seizure, as we discussed, it has a post-ictal confusion phase. And also we'll have to ask for other associated symptoms the patient has. And also we'll have to probe into the past medical history, if the patient has any baseline structural heart disease, or any other abnormality. And also we'll have to see into the family history, as we discussed earlier, if there is any early or a family history of sudden cardiac death at an earlier age. And also we'll have to ask about the medication history of the patient. And we should also see for the associated injuries secondary to the fall or RTA due to the syncopal episode. And if the patient has more than 5 syncopal episodes in 1 year, it's more likely to be a vasovagal syncope. But if it's of a shorter duration, he's having multiple syncopal episodes, then it's a red flag again. And also, we'll have to see for the key characteristics, which is, as we discussed earlier, the rate of onset. Is it gradual or abrupt onset? The position on symptom onset, if the patient was standing, sitting, or supine. And also we'll have to ask for the duration and rate of recovery. Was it rapid onset of recovery or slow onset, gradual, long duration of loss of consciousness, which is more pathological for and it's a red flag. And also we'll have to see for the in case of cardiac event, it can be the presentation can be more of an abrupt onset occurring while, as we discussed earlier, the position, the sitting or supine position, and the duration of more than a few seconds. And this mainly attribute to or linked to the serious causes of syncope. Coming to the physical examination in syncope, so we'll have to see the vital signs initially. As soon as the patient arrives in here, the first thing we'll have to see is the vital signs. We'll take the pulse rate and rhythm. And if there's, we'll see for any tachycardia, bradycardia, or other dyslipidemias. If we'll have to see for the respiratory rate. If the tachypnea is the component is that can suggest hypoxia, hyperventilation, or pulmonary embolism. BP also has to be checked because the shock can cause decreased cerebral perfusion, hypovolemia, or medication use may lead to orthostasis. And temperature has to be checked. We'll have to see for any fever from sepsis, as it may cause volume depletion and orthostatic syncopes. And the orthostatic pulse and BP also has to be seen. We'll have to ask for the patient to be in the supine position for 5 minutes and take a BP reading and a pulse reading. And after we'll have make them stand. And after 3 minutes, we'll again reassess for the pulse rate and BP. And we have discussed the cutoffs as well. The systolic BP more than 20 millimeters of mercury and this diastolic more than 10 millimeters of mercury, or the pulse rate also more than 20 beats per minute can also imply a orthostatic hypertension. And we'll have to see for the skin color diaphoresis, which can suggest any decreased organ perfusion. We'll have to see for the head, eyes, ears, nose, oral cavity, and throat. We have to see for any tenderness and deformity because patient who has a syncope episode can have fall, and or patient can have an RTA as well, and these can cause multiple injuries. So we'll have to do a proper thorough secondary survey from head to toe examination. And then, we'll also have to see for papilledema. Papilledema implies an increased intracranial pressure and it points towards head injury. And laceration of tongue, it can point towards seizure episode, which is a tongue bite aspect. And the breath, we can see for any ketones from the ketoacidosis. And coming to the neck, we'll have to see for any bruit or elevated JVP. The bruit can be seen as part of the cerebrovascular disease, like CVA. And elevated jugular venous pressure is a sign of right-sided heart failure from the ischemia, myocardial ischemia, tamponade, pulmonary embolism. Lungs, we will have to see for crackles or wheezes. There is infection or left-sided heart failure from the myocardial ischemia or a pulmonary, rarely pulmonary embolism, because the pulmonary embolism doesn't cause much of the any does not have any significant clinical examination finding. So these crackers mainly points towards this heart failure component and the basal, basically the bilateral basal crepitations of crackers. The heart will have to see for the systolic murmur, which can be seen as part of the aortic stenosis or the hypertrophic cardiomyopathy, especially in the obstructive phase of it. And you will have to see for S3, S4, which is seen mainly in heart failure. We'll have to see for the pericardial rub, which is seen in pericarditis or tamponade. Abdomen has to be seen for any pulsatile mass, as in abdominal aortic aneurysm. The rectum has to be seen. We will have to see the stools for any gross blood or melena. We'll have to do a PR and find out any blood stain. If it is there, it can point towards anemia or GA bleed, and we'll have to see for uterine bleeding or an axil tenderness, and so it can be seen in ectopic pregnancy. And the extremities also has to be seen for pulse or BP variation, as it can be seen in aortic dissection or subclavian steal syndrome. Neurologic causes, neurologic examination, it mainly we look at the mental status examination and the focal neurologic deficits, as it can point towards seizure, stroke, or other primary neurologic disease. And coming to the investigations, we'll do a 12-lead ECG initially, which we can use as a screening tool to find out any rhythm abnormalities, cardiac dysrhythmias, conduction abnormalities, ischemia, or any cardiomyopathy changes. And we'll also have to attach the patient to a cardiac monitor while he is in ED to monitor for any rhythm variations. And also we'll have to see for the orthostatic vital signs to see for the orthostatic hypotension or bradycardia as we discussed. Yeah, hemogram has to be done to look for any drop in the hematocrit or SB to see for the anemia or GA blood loss. And also we'll have to do the electrolytes to see for any metabolic abnormalities causing the prolonged loss of consciousness, and the glucose has to be checked to rule out the hypoglycemia event. D-dimer has to be checked to look for any pulmonary embolism, and the cardiac biomarkers for the MI aspect. BNP is for the congestive heart failure, the prolactin lactate levels for seizure episode. Beta HCG or UPD has to be done for every female of childbearing age to rule out pregnancy, and a toxicology screen has to be done to be suspected drug-related syncope, and ABG has been done to see for any acid-base disturbance, hypoxemia, lactate, and a chest X-ray is done to look for any mediastinal widening in aortic dissection or a congestive heart failure. We'll be able to see the batwing appearance. And the cranial CT or MRI or EEG is done to see for any new onset focal seizures, and it's also done in trauma patients and in hydrophilic hemorrhage patients. Echocardiography is done to rule out, to see for any cardiac outflow obstruction, tamponade, or any thoracic dissection. CTPA is done in pulmonary embolism or thoracic aortic dissection, and reverse Q scan is done if the patient has a renal failure component as well, as we will not be able to do angiography. And abdominal ultrasound, the CT is done to look for any abdominal aortic aneurysm, and pelvic ultrasound for ectopic pregnancy. So the management algorithm, as we discussed, so initially patient presents with syncope will have to take a proper history. We'll focus on the syncope character, cardiac risk factors, comorbidities, and medication or drug use. And we're coming to the physical examination. We have to see, we have discussed just now. We focus on vital signs, cardiovascular, and neurologic system examination mainly, and we'll take a 12-lead ECG. And all patients except young healthy adults with clear cause will have to do a 12-lead ECG. And then there comes the directed testing in ED, which is which also we have discussed now. Based on the history and physical examination or ECG, we'll have to do an orthostatic test, hemogram, abdominal USG, CTPA, brain imaging, EEG, CT aortogram, BTSCG, etc. And the further evaluations has to be done. So coming to the proper management, we'll have to manage patients based on the underlying cause for the syncope. So we'll have to initially diagnose the patient of as in why the patient is having the syncopal episode, and the treatment further is directed at the specific cause. And we'll have to prevent the recurrences of syncope. And coming to the emergency management of syncopal patients, or we can say a first aid. What can we do when we see a patient having a syncope? So first we'll assess the patient to the ground chair or stretcher, and we will move the patient to safety away from any external dangers such as high places, water, electrical wires, etc. And we lay the patient supine, and we can raise the legs so that the venous flow to the heart is increased and the cerebral perfusion is maintained. And we will also have to assess the vitals, the pulse, respiration to distinguish any if the patient is in cardiac arrest or syncope proper. So we'll have to see for other signs as well, for any pallor, diaphoresis, seizure, like movements or any jerky muscle movements, so that we can see what the real cause is. And also we have to attempt to the attempt to arouse the patient should not be tried ideally, because if the patient stands up, he will again have a decreased cerebral perfusion, and the syncopal episode can recur. We should not immediately tell the patient to stand up and go, but we'll have to observe for the patient and raise his legs, as we said, so that the venous return everything is increased. And also we'll have to see those patients if the patient is in hypotension, which is not directly caused due to the asystole. We'll have to raise the legs and provide fluid resuscitation. We can give IV normal saline, and we can correct the hypovolemia. Then coming to patients with symptomatic bradycardia or high-grade AV block with hypotension, we treat it with atropine initially, followed by temporary cardiac pacing, and if it's ineffective, we'll start with adrenaline infusion or dobutamine infusion, and it will increase the heart rate. So severe hypertension may require with sometimes it can occur like that, and we'll have to start vasoconstrictors. The reflex syncope, we'll have to advise the patients to respond to the warning or the prodromal symptom which they will have and move to a safe position, ideally supine position. And if possible, we can also ask them to do certain maneuvers such as the physical isometric counter pressure maneuvers such as leg crossing or the lower body muscle tensing or the arm tensing. These actions can be done to counter the reflex syncope. And carotid sinus syndrome is due to the, as we said, the carotid sinus hypersensitivity. We'll have to ask them to avoid turning their neck using tight collars. That is, we'll have to avoid any accidental mechanical manipulation of the carotid sinuses. And also, these patients, there will be medications that may induce this hypertension, and those should be discontinued or reduced. And pacemakers are useful if the patient has a prominent cardioinhibitory response, such as bradycardia or systole. And the situation syncope will have to just give good hydration and avoid the lifestyle trigger factors. As in, we have already discussed, we should prevent the patient from having any constipation episodes or any in a less polluted environment the patient should be in, so as to not give the excess stress, the strain. The excess strain should be avoided for the situation syncope. Coming to the orthostatic hypertension, it is treated with volume expansion and avoidance of volume depleting medications, such as the diuretic use, and we have to reduce or stop vasodilators or any other non-negative chronotropic drugs as well. In case of autonomic neuropathy, the volume expansion won't be uh, great because the autonomic system mediated tone of the vessels are lost. So it won't be completely reversed with fluids, and but we still will have to give them a fluid trial in these patients. And medication-induced syncope, it's mainly due to the orthostatic complications of the medications or due to the pro-arrhythmic drugs. And it is mainly treated by stopping the offending medication and substituting it with an alternative agent, or we'll have to adjust the dose and reduce it, or we'll have to alter the timing of the drug administration. So cardiac syncope in arrhythmias, basically, if it's a VT, we'll have to give those drugs, amiodarone and the anti-arrhythmic agents, other anti-arrhythmic agents, and or we'll have to do an ablation or an ICD insertion. SVT also similar, we'll have to give the drugs and do a catheter ablation as well. In bradyarrhythmias, we have already discussed the drugs we give, and also we can maybe insert a permanent pacemaker as well. And aortic stenosis, basically, we can do the aortic valve replacement. And in HCM, we can actually do the septal reduction procedures such as septal myectomy, alcohol septal ablation. And if there are recurrent ventricular arrhythmias, we can place an ICD as well. So coming to the critical diagnosis to consider in syncope in ER, these diagnoses should not be missed. From an ER point of view, we have to rule out for myocardial infarction, life-threatening dyslipidemias, thoracic aortic dissection, critical aortic stenosis, hypertrophic cardiomyopathy, cardiac tamponade, pulmonary aortic aneurysm, massive pulmonary embolism, subarachnoid hemorrhage, stroke, CVA, toxic metabolic derangement, severe hypovolemia or hemorrhage, ruptured ectopic pregnancy, and sepsis. So these diagnoses, we will have to make sure we rule out all of these before disposing the patient. And coming to the selected potential markers of increased short-term risk. So if the patient is more than 65 years age, or if a patient is a male gender, or history of any CHF, congestive heart failure, or any cardiovascular disease or dyslipidemias, or any structural heart disease, or if the patient has a family history of early sudden cardiac death, or if there's any syncope during the supine position or sitting position, or if the patient has any dyspnea or shortness of breath, or any unstable vitals such as hypotension, BP less than 90, abnormal ECG, or the patient has anemia with a hematocrit less than 30% or SP less than 9. So these aspects, these histories or these signs basically imply that the patient has a higher chance of having more adverse cause for the syncopal episode and has to be admitted and investigated further. So in conclusion, we have discussed about the basic definition of syncope and pre-syncope, and we have discussed about the pathophysiology of syncope, the causes of syncope, the cardiac cause, neurologic causes, the reflex causes, mediated causes, and the other non-syncopal causes of transient loss of consciousness. And we are also discussed about what are histories we have to take, what are the examinations we have to do, and what are the basic imaging or the basic investigations which we have to do, and also the basic management for these syncopal episodes. And So the patients with significantly abnormal vital signs, recurrent syncope, or associated symptoms like chest pain, hypotension, the red flag symptoms or signs should undergo rapid evaluation. And the basically the ED evaluation of syncope is often inconclusive, and it should be differentiated from other non-syncopal transient loss of consciousness, which is important in further management. And also after history, physical examination, 12-lead ECG, up to 50% patients do not have a firm diagnosis and requires admission and further evaluation if there are any red flag symptoms or signs. And also, we'll have to do the stepwise algorithmic approach for syncopal events, and this will help to improve the diagnostic accuracy. So hope you have understood for the how you can evaluate and manage a syncopal episode in ER. Thank you.